Okay. Good morning or good afternoon, everyone. Welcome to the inaugural Global Health Compassion Rounds, which is being jointly convened by the World Health Organization's Global Learning Laboratory in Geneva and the Focus Area for Compassion and Ethics, or FACE, at the Task Force for Global Health here in Atlanta. My name is David Addis, and along with my colleague Ashley Graham, we're really excited to be hosting this event from here in Atlanta, and we want to thank you so much for joining us. I'd like to start with a few words of introduction. It was about 2 years ago that the Global Learning Laboratory at WHO broadcast a webinar entitled Compassion, the Heart of Quality People-Centered Health Services. The presentations and the discussion in that webinar highlighted for me the growing number of people throughout the field of global health who are keenly interested in fundamental questions about the role of compassion in our work. I would say that in general, as a field, many of us are motivated by a sense of compassion, the desire to alleviate the suffering that we see or experience or know about. And we also are, we see the evidence of the importance of compassionate care in our work, the importance of compassion in making us effective. But many of us are isolated. We work in systems where the role of compassion is not always clear, and compassion may not be a topic of frequent conversation. So this webinar grew out of a desire to provide a space for us to get to know each other, to learn from each other, and to be encouraged by each other. We wanted to provide the conditions for a global community of interest or a community of practice to emerge and to be nurtured. So today's webinar is a first step, or at least hopefully a milestone in that process. A few details before we get started. There are about 200 people confirmed to be on the webinar today or registered for the webinar. And we're so excited that so many people have signed on. But for that reason, we decided not to use webcams except briefly for our featured speaker. And if our other speakers want to use them, they can. But we've also decided to mute microphones. We can unmute them for particular speakers, and we invite your comments at the end of the session and then through email for any suggestions you have to improve the format or content of these webinars. I would say in advance, if there are technical difficulties that you're experiencing, please throughout the webinar, please contact us at the email address you see on the, actually the email address is not on the slide, but it would be face@taskforce.org, face@taskforce.org. Now our agenda will unfold as follows. In just a minute, I'll turn it over to Dr. Shams Syed at WHO for his welcome and introductory comments. And then I'll introduce our featured speaker today, Heather Howard, who is Senior Global Health Advisor at ALIGHT, which is formerly known as the American Refugee Committee. And she'll share her experience of bringing compassion into the front and center of that organization and the challenges and really rewards of doing so. And then I'll turn to several people that we've asked in advance to provide a few moments of reflection to Heather's remarks. And then we'll open it up to your questions and comments. And because we have so many people on the line, if you have a question for Heather or for our respondents, we please ask you who are on your computers to use the chat function to send your questions. We will collate those and then ask them. If you're calling on a phone and you have a question, you can email it to that same email address, face, F-A-C-E, @taskforce.org. We plan to wrap up in about an hour and 20 minutes from now, so a total of 90 minutes. and that will be noon Eastern Time in the United States, 5 p.m. Greenwich Mean Time. And the webinar will be recorded to facilitate our note-taking and capturing the essence of the conversation. So now I'd like to introduce Dr. Shams Syed, who's the coordinator of the WHO Quality Systems and Resilience Unit at WHO. I contacted Shams and his team shortly after their webinar on compassion 2 years ago, and I've just been really blessed by his vision and his strong advocacy of compassion at the center of quality healthcare. So Shams? Shams, you can go ahead, please.
Thank you so much, David, and for that kind introduction, and greetings to you all. Can I just check, David, whether you can hear me?
Yes, I can hear you very well. Thank you.
Wonderful. So it's a real privilege to be with you all today, and I won't speak for too long, but I just did want to make a couple of key points for us as we move into this exciting webinar. David has already alluded to some of the background related to this, but I'd like to make 5 quick points related to the work that we're doing within the WHO Global Learning Laboratory for Quality UHC, and in particularly, of course, on compassion. So the first point I'd like to make is related to the linkage between quality health services as part, of course, of the fabric of universal health coverage and the SDGs, and compassion. So when we think about quality health services, whether we're thinking about effective care, safe care, or people-centered care, compassion percolates all of that. But for us, and this is the design of the thinking around this, we recognize that this is an area that requires intense exploration. And as David highlighted, there are multiple thoughts and strands of thinking related to this that we need to explore and need to bring together. And that leads me to the second point in relationship to the humility that we should bring to this discussion. We know some of the answers, we know we have some of the experiences, but we certainly don't know enough. And we recognize the need to learn more on how compassion is linked with achieving quality, people-centered health services. And so that leads me to the third point related to what David has already shared with you in terms of the ethos of the WHO Global Learning Laboratory, which was launched nearly 3 years ago as a mechanism to share, to challenge, and to spark thinking. And sharing experiences and knowledge is exactly what we hope to do today. But really trying to remember that we should be safe enough to challenge each other on areas of controversy, because that's the only way that we will advance the cause. And in order to do that, we need to be open to agreements and disagreements related to compassion and its role in quality health services in order for us to spark innovation for the future. And the fourth point is related just as a background. We have, and I've had the privilege of working with David and his team over the last couple of years, done some scoping related to publications, organizations, and interventions related to compassion. It's also been a real privilege to work on a co-development call globally to understand how compassion is seen in patient care, how compassion is taken forward within health facilities, how compassion is embedded within the culture of an organization, and particularly interesting to see how compassion can sometimes drive national efforts at transforming health services and transforming the quality of health services. Some of the synthesis related to this is available on the Global Learning Laboratory, and I would encourage colleagues to have a glance. My final point is going back into history a little bit, and many of you will know Avedis Donabedian, the godfather, I would say, of quality, And one of the things that he emphasized, which sometimes gets ignored, is the importance of love as central to quality. So he in his words, love of knowledge and love of man, and his emphasis on living and working accordingly. More recently, coming to our Director General, Dr. Tedros, in a recent editorial in The Lancet, highlighted that quality is not a given. It takes vision, it takes planning, investment, and compassion, with meticulous execution, rigorous monitoring from the national level to the smallest, remotest clinic. So with that, I'm really looking forward to listening very carefully to the featured presentation from Heather, and of course to learning from all of the colleagues within this webinar. So back to you, David.
Thank you so much, Shams. I really appreciate your comments and your framing our conversation today and going forward. I'd like now to introduce Heather Howard, who's the Senior Global Health Advisor at Alight, and some of you may know it formerly as the American Refugee Committee. I first heard Heather speak a few months ago on another webinar, and she shared the experience of Alight as they intentionally reimagined their work and their organization with compassion at the center, at the core. And in addition to the fact that this story, I think, will be inspiring and instructive for us, it's also important to note that Alight is a humanitarian organization. We're meeting today under the rubric of global health, and we're exploring how compassion can come to the center of people-centered health services and global public health. But the same exploration is ongoing within the humanitarian world as well. Just as another example, CHS Alliance, which is an alliance of humanitarian and development organizations based in Geneva, with Melissa Pitati and Tanya Wood leading an exploration of compassion across humanitarian organizations as well. So we see this emergence, I think, of compassion and this yearning to bring compassion more intentionally into the center of our work, not only in global health, but also in the humanitarian world. So Heather, thank you so much for joining us today. We look forward to your presentation. And after Heather speaks, we will have some respondents or panelists to offer a few reflections. So Heather, the floor is yours.
Thanks so much, David. I just wanted to pop on quickly and say hello to you all. You know, I feel like the human connection piece is so central to compassion and cultivation of compassion. So I felt it important to at least pop on quickly and show my face, introduce myself as in person as I can get before I dive into my presentation. So really quickly at Alight, we've been on this journey really for the past couple years. Our journey to becoming Alight has been ongoing, I'd say, for the past 5 to 8 years. And really, the organization has been reimagining itself and thinking about how to show up differently in the world and how to really answer this this growing crisis of increasing numbers of people who are displaced. And it's easy in the face of that to be overwhelmed by the numbers, to really just, you know, only focus on the quote unquote life-saving, or what has been historically categorized as life-saving. And at Alight, we've really come to realize that you know, our focus needs to be on the humans that are affected by these crises, not the numbers of people affected. And so we think about scaling deeply. We think about offering human-worthy services, not going beyond just the mere availability of services. And so as Alight has made this transition, you know, as the lead for our global health and nutrition portfolios, I really began asking myself, well, what does that mean for us in this sector? How do we show up differently? How do we really live the values that Alight is trying to espouse in the world. So I'm really grateful to be invited to share this journey with you. It continues to be a learning journey. So I'm really looking forward to the reflections after I share with you where we are and what we've done to date. So I'm gonna stop the video and go on over to the deck that I've prepared for you today. So we've called this this project really a project within Alight, Amandi, this exploration of how might we unleash compassion in humanitarian services. And really, as I was mentioning, it began with this reflection about how we do a better thing in the health and nutrition space in humanitarian settings. And I came to this realization that there's this paradox in humanitarianism, and really among a lot of caring professions around the world, whether that's in humanitarian settings or Western settings. It's this idea that humanitarians are, we're really called to action out of this deep sense of compassion. But, as you look at, the vocabulary that the humanitarian community uses, the stated values, certainly the metrics, compassion is largely absent from those conversations. And, as I was saying at Alight, it's really, we believe it is our duty to honor the humans, to show up and serve the humans that are affected by these emergencies around the world. And so that's how we're thinking about addressing this situation differently, thinking about this paradox, creating space in the conversation about compassion as central to quality of care. As I mentioned, the numbers are staggering. Most of you are familiar with this statistic that UNHCR put out last year, that there's 70.8 million people in the world who are currently displaced in the world. And there's somewhere upwards of 250 million who are actually migrants in the world. This is a staggering number, but to me, it represents an opportunity for us to do a better thing. And there's nascent research that shows that embracing compassion and making it central to the conversation and a core tenet of quality of care is actually a life-saving endeavor. When I initially began to socialize these ideas among some of my humanitarian colleagues, there were some reactions, things like, well, it's nice to be nice, but that doesn't save lives. And in fact, there is research that establishes that patients who perceive they have been treated kindly and with respect actually recover more quickly and have better overall health outcomes. The typical or widely accepted understanding of access issues are things like distance and financial barriers. And in fact, there's research that shows just the opposite, that people are actually willing to travel further and pay more for services if they believe they will be treated with compassion, respect, and dignity at that healthcare facility. And that's research that's been done in developing countries. And furthermore, on the staff side of things, compassionate care environments or compassionate organizations have showed that they're able to actually attract more highly qualified staff and hang on to those staff for longer, lowering their turnover. So there's a lot of, like I said, nascent research to suggest that investing in this is really important. And so we turned this into a how might we question. We at Alight like to use human-centered design processes to solve big thorny questions. And those often start with a well-crafted how might we question. And so we're asking ourselves, how might we unleash compassion, really make space for it in humanitarian services? again, really valuing that human connection. So we want to create experiences of connection and meaning, not just for the clients that we serve, but also for our own staff and for the wider communities that we serve, be it a refugee community and or the host communities that we also interact with. So like I said, we've been on this discovery journey for about the past 2 years at this point. And this isn't really a linear process. I'm presenting it to you linearly because that's what makes sense through slides. But discovery leads into co-creation. We discover new things through co-creation that add to our understanding. We move into prototyping and iterate those prototypes. But it's really a very fluid process. But I want to share with you some of the insights that we've discovered through the past couple years. And the first one is that clients really do value compassion and they want more of it. So something that we did early on in this exploration is we actually looked into our own database. We have a pretty innovative client feedback mechanism called Kuja Kuja. And I welcome you to explore that on your own time, kujakuja.com. And it's a simple customer service interface. You might have seen something similar at even fast food restaurants or at the airport. When we simply ask, you know, how was your experience today? And we have customer service reps out there with tablets actually, and the client can pull the smiley face that they see, or actually it's just a face with no expression. They pull it to the right, it turns to a smiley face. I was happy with my service. They pull it to the left, frowny face. Wasn't so great today. And then we ask one simple follow-up question: what could we do to make it better? And so we log all of these responses, and then we've been mining this data. It's currently, Kuja Kuja is currently running in 4 countries. 4 of Alight's countries, and we're currently launching with UNHCR in Latin America. And surprisingly, people are using compassion in their own words to describe what they value in services, and sometimes to tell us where we can be doing better. So, you know, this quote demonstrates that if I were running the service, I would welcome my patients in my consultation room with a friendly face and compassion. You know, other times people would say things like, you know, actually the nurses need to put their phones down and pay more attention to me. So we've been getting feedback from our own clients where we're doing well on this front and where we need to improve. But it's really demonstrated to us that it is important to them in their care. The second insight that we've come to is that our staff are deeply compassionate. We just need to make space to celebrate it and really to cultivate more of it, to unleash more of it. You know, this isn't a situation where, you know, humanitarians or frontline staff or the organizations that support them are devoid of compassion. That's not what I'm saying at all. I'm saying we all have it. And in fact, I believe it's an intrinsic human quality. But because there isn't space in the conversation for it, there's really no room for it to flourish. You know, you can plant a seed, but if you don't water it, it's not going to grow and bloom. And so another thing that we did early on in this journey is we ran a staff challenge. Now, Alight has almost 2,500 staff globally. And we asked them, what does compassion mean to you? And how do you see it show up in your work? We got over 900 responses, which again really underscored the fact that compassion exists. Our staff know what it is, and we just need to, you know, celebrate it, reward it, create new conversations to be able to explore it more deeply so that it can really take root and flourish. And furthermore, we saw that our staff really understand what compassion means to the people that we're serving, as you see in the quote here. Something as simple and basic as a smile, they know reduces anxiety and depression in the people that we're serving. It may seem difficult when there's a line of patients, you know, 50, 70 people deep out the door, to be able to take that time to connect, even for a few moments with our patients. But if it's going to end up serving them better such that they recover more quickly, have better health outcomes, it means they're less likely to end up in that line again tomorrow. So maybe if we invest in compassion, we can also start to improve our patient outcomes, which means that the overall burden on the health services may at some point in the future also start to reduce. Our third insight. This is something that we developed through iterative co-creation. And I'll tell you a bit more about who we've been co-creating with a little bit later on. But particularly at one of our co-creation workshop in Rwanda this past summer, we co-created a definition of compassion with our clients, with our frontline staff, with brilliant and diverse minds from around the world. And really it came down to these three things. It's about being seen, it's about being heard, it's about feeling valued. And that goes for the people that we serve, that goes for our own staff. I think basically this is what all humans are seeking. And if we can accomplish this, I think that's truly what's at the heart of providing humanitarian services. Yes, we need to offer shelter. Yes, we need to offer water, healthcare services. But when, all of those, everything that contributes to a person's identity, contributes to a person's sense of belonging has largely been stripped away because of a crisis, a war, conflict, an environmental disaster, they just want to be seen as human, not as a product of their circumstances. And so if we can offer this to them, to me, that's truly accomplishing the humanitarian mission. The fourth insight, aim to delight. So we've also done quite a bit of analogous research. So going beyond just the humanitarian settings where we work and looking at things like the service industry, hospitality industry, fine hotels, fine dining, credit unions, boutique fitness clubs, all those places that really offer you a sense of belonging, that continue to attract their customers over and over again. And one quote that sticks with me from an interview that I conducted with the head concierge at the Hay Adams Hotel, which is a very historic hotel in Washington, D.C. He said, I asked him about what is his approach to customer service, and he says, I always try to delight my clients. And that really gave me pause. What if that was the framework from which we were operating in delivering healthcare services in humanitarian settings? We've moved, the majority of humanitarian crises are protracted settings. And so even though in the news, they're largely characterized as the acute settings, the majority are these long-term situations in the Congolese refugee camps in Rwanda, for example, where we work. And so we moved beyond the simple availability of services. Now, what if we tried to delight our clients? What would that look like? It gave me it just opened up a whole new, all kinds of new opportunities and creativity to think about how we could really improve the client experience. Insight 5, again, is drawn from some of our analogous and experiential research. I had the good fortune to attend a medicine and compassion retreat here in the Tetons in Wyoming that was led by a Tibetan Buddhist Lama, a very well-renowned Lama, as well as a physician who has since become a Buddhist teacher. And Pakchak Rinpoche, the Lama, said this, a calm mind is a kind mind. And so often in humanitarianism, in global health, in everyday modern life, we have this deluge of information. Things are coming at us from all sides. We're barely able to keep our heads above water. Everyone's overworked. But if we can find time and make space actually for our staff, for ourselves, to be able to cultivate that calmness of mind, we're going to be able to treat people more kindly. We're going to be able to show them the love that is in our hearts and the reason that has brought us to this work. And so, you know, there's dozens of different techniques to cultivate this calmness of mind. Of course, at this retreat, it was, you know, Buddhist love and compassion meditation, but, you know, transcendental meditation, simple prayer. Start where people are already and offer them opportunities to cultivate that, because they'll be able to show up better to work when we offer that for our staff. And then our last insight, insight 6, is just that compassion really needs to be embedded throughout all levels of an organization, throughout all levels of a system. And so we've really been thinking about bringing a systems thinking approach to this work. You know, it's not just, this isn't a matter of just, you know, training our frontline people. You know, I sit in our Minneapolis office. We have people in other support functions in our country offices in capital cities and elsewhere. You know, these are practices, cultural organizational norms that need to be really lived throughout the organization if we're really going to make a difference in the client experience. So now I want to move on to some of our co-creation efforts. So this is just a smattering of the organizations that we've been engaging with as thought partners, people who have come with us, joined us for various co-creation events. And there have been a number, really dozens of individuals. Some of you are on the line with us today who have contributed to this effort and to deepen our thinking, to challenge us, as Shams was saying, about how we develop this initiative and what is needed to really, you know, pull the levers to unleash compassion. So we had a couple events earlier this year. The first one was with United Health Group. Took about a half day and did a co-creation exercise. The second one was actually at Medtronic, which is, for those who aren't familiar, a biomedical device firm, actually one of the largest corporations in the world. And they have an innovation team that is staffed by human-centered designers. And they were really interested in this project, in this endeavor, and wanted to partner with us on it. And so we first did a co-creation exercise at their innovation lab here in Minneapolis. And then they've been partners with us as we've moved forward from that day, working with us to develop the tools that we needed for our next co-creation exercise, which we conducted in Gihembe refugee camp in Rwanda. We had a team of 11 travelers from the US and the UK. We were joined by Alight staff members from Kigali, as well as the front lines here in Gihembe, as well as community representatives. So really a diverse group of individuals. And we spent 3 days together, really deepening our understanding of what is compassion, starting to brainstorm some ideas about how we might cultivate more of it at the front lines, and getting feedback about those ideas from each other. By the end of it, we were able to really blow out some ideas and think through how we might implement some prototypes in the camp. So I'm going to move into some of our thinking around prototypes. As I mentioned, we've really been thinking about this in terms of a systems thinking or a systems level approach. So we've been thinking about developing initiatives that are client facing, initiatives for our staff. You know, if our staff are better supported, better motivated, the thinking is that they will be able to treat our clients better. I think it was Richard Branson that said, you know, you have to treat your employees as your primary customer, and if you take care of them, they'll take care of the clients. Also thinking about how we embed this at an organizational level, whether it's through the way that we do recruitment or other HR policies. Is it embedded in regular check-ins between supervisors and supervisees? Are there meeting norms that we can adopt that really promote compassion? Are there reward systems that we can offer? And then also at the wider community level, you know, we need to ensure that the community values compassion as much as we do. And so how can we also unleash compassion at the community level? How do we cultivate that conversation throughout the community? Can we create ambassadors at the community level for compassion? So I'm leading you a little bit into some of the areas that we have finally sort of are starting to circle around when it comes to prototypes. We have a number of ideas and they've circled around these topics. One is healing environments. So those are ideas like, you know, we really want to transform these service sites to communicate the value, how much we value our clients. So spaces that are warm and inviting, that really welcome people to open up to us, that are clean, that really reflect our own values about the services that we provide. I'm not going to go through all of these because I'm just going to offer you a few in the next slides really quickly. Conversation and connection. As I mentioned in the very beginning, so much of compassion is really cultivated through that human connection piece. So how can we foster more connection and build stronger relationships between our staff and our clients outside of those service sites to really cultivate that shared humanity between us? So it's less of this vertical service delivery relationship. Staff wellness is so important. And this is some of the work that Melissa at CHS has been really pioneering, but thinking about how we take care of our own staff is really important in creating, you know, sometimes the policies are there within HR, you know, the breaks and the vacation, but often, particularly I think in the humanitarian community, there's a lot of guilt around actually taking those benefits that are offered. So how do we really shift our own organizational culture and the expectations and the norms to promote staff wellness initiatives and taking care of oneself, really that self-compassion piece. Valuing and celebrating compassion when we see it. We've been imagining things like a compassion rewards program, almost something like it's been suggested, something like a letter jacket in the United States, or for those unfamiliar with letter jackets, something almost like a military lapel where you see all of the accolades, the different pins that someone has received for various levels of achievement. You know, could we create something similar, create criteria for compassion, and people earn these? And so, you know, when they're walking around with their white coats in the clinic, people can see it, and the staff themselves can feel proud of what they've accomplished. We've also been considering things like, you know, an annual Global Compassion Award for staff, and perhaps even doing something similar for community members. I've been talking a lot about client experience. I'm going to talk about one idea related to that in the next slide. So I'll go there now. So like I said, through the Rwanda co-creation exercise, we got to the point, not of a detailed prototype, but certainly some deeper thoughts about what might actually work in these settings. And one that came out really strongly and was responded to very positively by all the folks in the room was this idea for a community health liaison. And this came out of an exploration of trying to look at this intersection between improving client experience, but also improving clinic efficiency. I think often accomplishing both of those at the same time is seen as a rather difficult task, but this idea really answered that challenge. So often we find in our clinics that our frontline staff are having, you know, our clinic is not a big space, but even still people unfamiliar with this space need some help, you know, navigating around. And so our own staff end up, you know, walking patients from the registration area to the consultation room, from the consultation room to the lab, from the lab over to pharmacy. And more than that, you know, as I mentioned, the patient lines, the patient burden is really quite high. And so our frontline staff don't have a lot of time to really just talk and listen with people and hear their concerns. And we really want to move beyond, you know, our frontline staff becoming quote unquote nexperts. You know, what are your symptoms? Here's what I think you have. Here's your prescription. Next. We want to create, as I said, these experiences of meaning and connection. And so this community health liaison idea is a way we would identify community volunteers who can really act as a navigator, help patients get from one space to another in the clinic, and also train them in psychosocial support so that they can be that listening ear for people if they, you know, wish to unburden a bit. Another idea that we came up with, and this was actually a community generated idea that perhaps got the strongest positive response out of any of the ideas shared during that workshop. And that was to create an on-site, we haven't decided what to call it yet. Call it a non-denominational chapel, call it a sacred oasis, but really a space where people can have some silent reflection, can go for prayer, can meditate, can just you know, commune silently with others, and have that quiet space. Going back to that insight, a calm mind is a kind mind. And this would be something that could be used by patients themselves, by their families, by our own staff. You know, in some of our discovery and empathy building in the camps, you know, we ask people, what sparks joy for you? And it often came down to two things. It was prayer and music. And so, you know, this is a way that we can offer a space for people, well, when they're suffering, you know, they come to the health clinic because they are suffering most often, to be able to find some of that joy, that solace, that thing that comforts them. And yes, it can be done anywhere, silently with oneself, but offering that space is really a way to honor that which people value most. And alongside this, it was also suggested by this community leader to provide on-site religious support. So really offering chaplain services for inpatients. And then going back to that music comment, also playing music in the wards, and that would be a pretty cheap and easy thing that we can do. So these are the two prototypes that we are currently developing. You know, these, the first one, the community health liaison program, is something that we can do, you know, relatively low cost, and we believe we can iterate it quite rapidly. We'll need to do a little bit of fundraising for the Sacred Oasis space, do a little bit more discovery about what people desire in this space. But there's also some really small things that we've started doing, ways that we can really communicate compassion, support, motivation to staff and our clients. So we found out through this process, and this is me being transparent and vulnerable to you, we found out our staff didn't even have a water cooler at Guillain-Barré camp. Quite embarrassing, but once senior leadership found out about this, I mean, it was the next week that they had clean water available to them on site. So our staff no longer had to either take time away from patients or, you know, pay a community member to go fetch water for them. We'll soon be started something as simple as just weekly gratitude notes between staff members. So a simple practice, 2 minutes at our Friday morning meeting to write 2-3 notes to colleagues and mention something you appreciated about what they did that week. And there is research that substantiates that the cultivation of a gratitude practice really opens up and cultivates more compassion and kindness, and also orients people towards a more positive, optimistic mindset. So these prototypes that I'm sharing with you, yes, are going to take some design work, some testing work, but there's also some really small things that don't take, hardly any effort at all for us to move forward with, to start building that culture, creating the norms and the expectations around compassion in our organization. There were many, many more ideas that were generated throughout our co-creation exercises and endeavors this year. I could speak for another hour about all of them, but I want to offer, the opportunity for the people who will be sharing some reflections to provide some feedback, hopefully challenge us on ways that we could continue to deepen our inquiry. And also from all of you, I'd love to hear your feedback, to hear how you're thinking about this, starting to take this on in your own organization. So thank you so much again for the invitation to share this with you today. I'm really delighted to be a part of this community that values compassion as much as I do in this work. So I'll end there for the moment.
Thank you very much. Heather, that was really wonderful and an inspiring and challenging presentation. Thanks for walking us through this development of compassion within Alight, and also reminding us that this is a work in progress, and just helping us see that compassion really is made up of a myriad of details. We'd like now to have some respondents, and I'd like to turn first to Dabney Evans, who's a professor at the Rollins School of Public Health at Emory University, director of the Humanitarian Emergency Center at Emory. Dabney, I know that you're on a tight time frame, so please go ahead and provide us your reflections. What ideas were sparked? What touched you about Heather's presentation? Thank you very much. Dabney, are you there?
Thank you so much, David. Can you hear me?
We can, thank you.
Fantastic. And thanks to you, Heather. This was really a fantastic sharing, and appreciate all the work that you've done on this. I guess I would just share two reflections in thinking about some of the issues that Heather raised in her presentation, and thinking about my own, thinking around this. One of the things that occurs to me is thinking about compassion in our work as both compassion for others as well as for ourselves. So I was really happy to see, and I think it was reflected a little bit in what Heather shared about the importance of psychosocial support, but also in the chat box, a number of people were mentioning things like trauma-informed care, patient-centered care, and then survivor-centered care. So, and that was something that had occurred to me previously as well. So I think that really centering the patients or the clients, however you want to think of them, is really critical to centering compassion. And for me, when I think about this, I think of healthcare environments as a microcosm of the world. And one of the things that we know about things like norms change is that they take a tremendous amount of work. So I think that just as important as it is for us to focus on patient or clients, we also need to think about compassion for ourselves. And that's something that is sometimes forgotten, as demonstrated by Heather's example of the water cooler. So I just would add as another layer the importance of self-care. I myself am a Generation X person, which is not known as a generation big on self-care, but one of the things that I really admire about the millennial generation is their demand for self-care. And so I think that that's something that we really need to consider as we move forward with this approach.
Thank you so much, Dabney. Appreciate your joining us and for sharing those comments. I'd like to go next to Chintan Maru, who's an entrepreneur and independent strategy consultant focused on value-based healthcare. He's exploring opportunities to launch a venture in India, and he currently joins us from India, where it's quite late. So Chin, thanks so much for hanging in there with us, and we'd love to hear your reflections.
Great. Yeah, maybe just a quick reflection from my day here. I spent the day facilitating a workshop on patient-centered tuberculosis care. And TB is a great example where there's a clear utilitarian case for compassion. If you can retain patients, keep them engaged, they would finish their 9-month antibiotic treatment course, for example. And so with the belief that we should measure what matters, we started today thinking about what are the metrics on compassion for this TB pilot that we should include. And we ultimately want to be able to plug sort of compassion into an Excel worksheet, if you will, to show how it can save lives and make care more cost effective. And on one hand, I think that utilitarian framing is really important and powerful. And I love how that comes through in Heather's presentation. And I'm trying to aspire to that in some of this work myself. I think it can push decision makers to make it a priority. I think it can help us make a business case to attract more resources for this compassion, people-centered care. On the other hand, I'll confess to you, and I want to pose this as a question to you all, just to think about. I'm having even some self-doubt on that utilitarian framing, and I'm wondering if it might, in a small way, undermine our goals, and if the better path to organizational and cultural change is one that might communicate and prioritize compassion for compassion's sake. So yeah, just a question for you all.
Thanks so much, Chin. That was for that challenge as well. So I'd like to, and I'd love to come back to some of these thoughts that both you and Dabney raised. Dabney raising the issue of self-care and self-compassion. And you're raising the question to us, to what extent do we make a utilitarian argument for compassion? At what point might that become counterproductive? And when might it be useful? And how do we balance that? Great questions. Our next respondent is Tara Hopkins, who's a co-executive director at Molly Health. I've been in touch with Tara over the last couple of months after a meeting at the Izumi Foundation, and I've been challenged by some of her thoughts and questions about compassion. And so, Tara, I look forward to your reflections now.
Thank you, David, and thank you, Heather, for that very interesting and informative presentation. It's really nice to see sort of inside the way that another organization is thinking about these questions. I work in a small community health organization, and one of the things that we really have been thinking through is how to operationalize these concepts, both within our organization and with our partners. So I learned a great deal from seeing how you're doing that. Working at the community level, of course, we see the relevance of compassion in our daily work in myriad ways. And for us, working in very low resource settings where the resources and inputs that we have to improve the quality of care are limited, something that Heather said really resonates a great deal. And that was the co-creation definition that was helping patients to feel that they're being seen, being heard, and being valued. That is something that we can achieve even at the community level in very low resource communities. So that was something that really resonates with the work that we're doing to bring both patients and providers together to improve quality of health care. And even if we can't have a big impact on the type of clinical services that are provided or the type of equipment that's available, that work of helping both providers and patients feeling seen, heard, and valued is, I would say, is really the core of our quality improvement work. I'm also very interested in, beyond just sort of the applications or integration of compassion into our daily work, I'm really interested in that intense exploration of compassion that was brought up earlier. And I think some of the most interesting questions about compassion that have arisen for me have been around questioning what is the role of compassion can it not just be a function of alleviating suffering, but can it also be a function of interrogating suffering? And some of the dynamics that exist within our sector revolve around a lot of sort of unspoken relationships to power. And when we're talking about the alleviation of suffering, in my mind, that goes to deeper questions of who has the ability to alleviate suffering. That is a power that, for example, a provider might have. So how are we using that power within the context of compassion, not just maybe on that provider-patient interaction, but on some of these broader scales? So as we're looking at, how is compassion being integrated into national frameworks? How are we thinking about compassion even on a global scale? What are the conversations and interrogations that compassion perhaps could lead us to, if we take these concepts a little bit further? And if I could share, one of the most interesting parts of the conversation that I've had the privilege to be a part of is even just looking at the word compassion and its definition across cultures, contexts, and languages, and really unpacking that. So where I work in Francophone West Africa, how are we using the word compassion? What are the sort of historical definitions and legacies that might be tied into that? What are the connotations that we or others bring to the word? And maybe there's, I wonder if there's not work for us to do as a community to really carve out what compassion is for us, not just in terms of our daily work, but in terms of, again, that interrogation of suffering. So again, I go back to that definition that Heather offered during her co-creation process as one that really resonates. And I'm very interested to work within this community and hear from others about the way that we're making definitions and meaning around compassion. So thank you for this opportunity, and I'm so pleased to be a part of this community and really looking forward to learning from you all.
Thank you so much, Tara. I really appreciate your addition to these reflections, bringing up the issue of power dynamics and compassion at a deep level being a way to not only alleviate suffering, but also to interrogate suffering and to interrogate our relationship to our work and to compassion itself. The floor is now open for your comments and questions. And again, your microphones are muted. So if you have a question for any of our speakers or a comment, please send it to us using the chat function on your computer screen. Or if you're on a telephone, you can also email us questions at the email address face@taskforce.org. We've received a couple questions already, and one of these was related to metrics. Now, Jin, you raised the issue of metrics, and you're starting to look at sort of metrics for compassion in your work with tuberculosis. There's another respondent that I would like to bring online, Daniel Bursa, who has done work in the country of Ethiopia on a health sector transformation plan, bringing compassion and respectful care to the very center of that plan. I'm curious, Daniel, specifically, if you could share with us how you're approaching the issue of metrics and measuring progress towards that goal of compassionate care and respectful care in the context of a national health system. So we'll try to bring you on now, Daniel.
Thank you, David.
Very good. We can hear you.
Okay. Thank you very much. I'm very happy to hear that a lot of like comments and reflection on the on this agenda, especially on compassionate care. It's like the heart of the quality agenda. As you clearly said, one of the transformation agenda that we have in the national strategic document is compassionate, respectful, and caring professional. Because when we talk about quality of care, people talk about like infrastructure, information system, logistics, and HR. But when we say HR, most of the time people talk about the mix, the number of health professionals that we have, but we miss the important part, that is compassionate care. So the soft part is very important. After you have like the infrastructure, the information technology and everything, if you are not engaging the health workers who are working at the facility level, you can't achieve the target and the goals that you have in the and in your national plan. So that's why we put that as a transformation agenda. So we are just like implementing that for the last 4 years at national level. So to that end, we have just developed like training materials. We give like TOTs and different basic training for health professionals at all levels. Because one of the theory of change and the principles that we have is that compassion can be learned, and we can create like a compassionate health workforce by just giving training and by just showing that how the compassion can change the way that we do business, especially when we communicate with patients and families and the system as well. So we have done that. When it comes to specifically to the measurement part, that is one of the challenge and one of the problems that we have, because we can't directly measure compassion. Probably there are some proxy indicators that we are using. One of it is patient satisfaction rate, but there are a lot of like contributing factor to have like patient satisfaction rate. And also it's very important to note that we are just discussing with Harvard and other colleagues to work on the measurement and evaluation aspect of the compassionate care, because we are just investing a lot on the compassionate care, but people wanted to see that how directly that investment that like improve the quality of care and or compassionate care. That's one of the issues that I would like to raise. But learning, we have learned it like a lot of experience from our implementation plan, and one of it is I explained compassion can be learned, and also we need to create like champions who can bring compassion at all level. And probably to this end, our health sector is we are just we bring compassion at higher level, and the champions are the politician and like the leaders, the health leader, including the deputy prime minister, were on the podium when we launched the compassionate agenda at the national level. And so creating champions is very important. And the other learning, probably we are just trying to integrate the agenda of compassion in health science and medical school curricula, and that is also a very important part of the the ethics trainings that we give in the school.
Thank you very much, Daniel. That was very helpful, and it's really staggering for some of us who work at smaller units of complexity and size to contemplate a compassionate national health system. So thank you very much for your insights. I'd just like to raise this question. If there are other panelists who would like to comment on this issue of metrics and measuring compassion. I mean, Daniel suggested that it might be hard to measure it explicitly, but there might be proxies. And Chin, you mentioned looking at this issue, and there might be other panelists who would like to comment on that as well. But Chin, would you like to share anything related to metrics of compassion from your work? Oh, it sounds like Chin might have had to drop off and get some sleep. So we'll try to maybe schedule our call a little bit earlier next time. Oh, I'm hearing some signal, but I'm not sure what it is. Do any of the other panelists want to comment on that particular question of measurement or metrics? Or open this up also to you, Heather, and to colleagues at the World Health Organization.
I can jump in, David, although I'm very curious how others are thinking about this as well. I think it sounds to me like this is something that we're all wrestling with. So we've also been thinking about, okay, if we implement some of these initiatives, we want to see, is it moving the needle at all? And I showed you, you know, kind of how we're thinking about this as a systems level initiative. And so we've done quite a bit of research at, you know, the client, staff, organization, and community level about different measures that we might explore using. And so, for example, at the client level, I mentioned our Kuja Kuja tools. Certainly we can use that as a very basic measure of client satisfaction. But we've also found things like the CARE measure, which is a 10-item scale that measures holistic patient-centered care in clinical therapeutic relationships. This was something that was developed by Dr. Stephen Mercer actually almost 15 years ago, but I think it'd be something that'd be relatively simple to administer, maybe not on an everyday basis, but certainly if we, you know, developed a study of some sort. So it's measures like, you know, how was the doctor at making you feel at ease, at letting you tell your story, at really listening, and the list goes on. On the staff side of things, you know, certainly we're thinking about measuring staff retention as a way of evaluating ourselves of how we're changing as an organization to be a more compassionate organization. There's the Copenhagen Burnout Inventory that we're toying with using. Kirsten Neff, who's kind of the well-known scholar on self-compassion, has a 12-item scale that measures things like self-kindness, self-judgment, common humanity. So if we really developed some tools, techniques, or programming around promoting self-compassion, that might be a measure that we could use. When it gets up to the organizational level is where it starts to become, for me anyways, a little bit more murky. You know, in the literature I did find there's, and Vogus has a compassion practices scale. There's also some quality indicators around creating an enabling environment for compassion, but I'm not sure they're entirely fit for purpose. And so this might be an area of work that this community, as it continues to evolve, starts to take on itself. And just finally, on the community level, you know, if systems level is murky, I think community level, I'm really unclear if we got into community programming around this, around compassion cultivation, how we might measure it. You know, I've been thinking about things like community collective efficacy. Would that be a useful measure? Social cohesion, some of these upstream measures that might be able to reflect in some way whether any of our work to cultivate, foster more compassion, more compassionate attitudes would contribute to moving the needle on some of these. So those are just a few ideas that we've been considering.
Thank you very much, Heather. I think this idea of compassionate communities is something we can learn quite a bit from the whole Charter for Compassion movement and the cities that have signed on to become compassionate communities or compassionate cities. So I think there's, as you pointed out, there's a lot that we can learn from that's already sort of out there. Shams, do you have anything you'd like to add from the side of WHO on this issue of metrics?
Thanks,
Thanks,
David.
David.
Getting some feedback from you, Shams.
Can you hear me now?
I can. There's some feedback. I think, but go ahead, please. Yeah.
Okay.
Good.
So this is a really, really important question, and I suspect that the answers that we will provide are going to be reasonably unsatisfactory, just because it's one of those wicked problems that we need to solve together. Couple of quick thoughts, though. I think the conceptual clarity that we're seeking on compassion is still somewhat elusive. And without that conceptual clarity, it's a little bit difficult to get down into the measurement aspects. So this is something perhaps just to highlight. While there's, of course, lots that's been done related to measurement of compassion in a specific setting, trying to do it at a system-wide level is perhaps the challenge that we will face, and it's a good challenge to have. Couple of quick thoughts on how we might approach it. One of the reasons why the linkage with quality health services is an interesting one is that each of the domains of quality traditionally considered, such as effectiveness, patient safety, and people-centeredness, certainly the three core domains, while of course others exist as well, have specific subdomains that would be very nicely linked up potentially to compassion. And of course, particularly on the people-centeredness side, whether that be patient-reported outcomes or patient-reported experiences, that might be an interesting avenue to consider. The other frame of reference that we might also want to consider is how measurement would be taking place on compassion all the way from the community level to the point of care, to the facility, and then particularly how districts are organizing. And I'm particularly focusing in on low and middle income country settings, but this is equally applicable to other settings where there is an organization that's responsible for delivering services for a specific population group. And then the point that Daniel was making related to national level transformation agendas, there's a real opportunity to measure how that's moving forward. And of course, they may be more process measures, but it's still going to give us information, or at least a spotlight on the role of compassion and the linkage with quality. The final point to make mention of is the domain of quality that often gets ignored is equity, and that slice could be a really interesting entry point for measuring compassion. And I really, coming back to some of the points that were made earlier, alleviating versus interrogating suffering, that would be a really interesting area to unpack that Tara mentioned earlier. But I suspect there's a lot of unpacking to do in this area, and would certainly be a very interesting area for co-development.
Thank you very much, Shams. Great thoughts. We've gotten several other really important questions, and I'm also mindful of our time. We initially thought that we might be able to schedule this for 60 minutes since our lives are kind of organized in 60-minute blocks, but we extended it to 90. I think we could extend it to 900 and still have things to talk about. So what I'd like to do is to just mention some of the other excellent questions that have come up and let you know that we will note these, and we will also perhaps share them, as well as perhaps point to some resources or answers in a newsletter or in an email to you in follow-up to this webinar. The question came in very early on. Does compassion influence doctors' burnout? We were talking about making people compassionate or encouraging them to be compassionate, doesn't that just open them up to burnout? What do we do about that? And this goes to the point that Dabney Evans raised about self-care. Another question that Daniel touched on about, can we actually teach people to be compassionate? Daniel answered quite strongly in the affirmative, but this is a question that comes up. At what point in the life course can compassion best be learned? Can we teach people to become compassionate if they don't want to learn? That may be much more difficult. There are compassion training courses from a variety of different perspectives and traditions. So I think the emerging answer on that is that yes, if people want to learn that, it is something that can be taught and learned, but it's still an important question. One of the questions came up was wanting more practical ways to promote compassion in health systems and in health facilities. And we heard several suggestions from our panelists and from Heather, but there was a desire for more concrete examples and particularly how to give a voice for individuals and organizations to share their experience and inspire others. And my initial response to that question is that's exactly the intention and the hope for this series of webinars. There were several other questions that came through, and we will share those with you. I'd like now to move towards sort of wrapping things up. We'll give Dr. Syed the final word from the World Health Organization, but I'd just like to thank everyone for joining us today. This has been really exciting and very rewarding and affirming for us. I'd like to thank our panelists, thank Heather, especially for her presentation and sharing her experience. I'd like to thank the staff here, especially Ashley Graham, who's really been the driving force on this side for getting the systems up and running and organizing the webinar today. We, and by we, I mean us here at FACE, at the Task Force for Global Health, but also the group at WHO, would like to make this at least a quarterly event. And we welcome your thoughts and comments on how to improve the format and content. If you'd like to suggest themes or speakers, please send those suggestions to us at FACE at taskforce.org. We will summarize today's webinar and send it to you and to others who were unable to attend by email. If you have announcements or resources or upcoming events that you'd like to share with this emerging community of practice, please send them to us and we'll distribute them to everyone. And we welcome your ideas on how to further catalyze this community of practice, how to share these ideas, how to take the conversation to a different level, and how to begin interacting with each other. We're gratified by the tremendous response to this call, and we realize that the format makes interaction at the individual level very difficult. So help us figure out how to do this better. So we look forward to hearing from you. And Shams, I'd like you to bring the meeting to a close after your final remarks, please.
Thank you very much, David, and thank you again, everybody. I thoroughly enjoyed the time that we've had together, and particularly how Heather went into some of the weeds related to the insights that has been that she's gathered over the years. One of the things that really jumped out at me is particularly the Amandi piece, is that there was a blank box, Heather, and I'm not sure whether that was deliberate, but certainly there's still a lot to explore on that slide. So the openness is really something that we was well noted. I think the other point that I wanted to make is that I think Dabney mentioned that healthcare environments are a microcosm of the world, and I think that's particularly important because of the world that we're currently living in. And there's actually an increasing momentum around the concept of health as a bridge for peace. And I think that's something that we shouldn't ignore, and we should really think a little bit